Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. You know, when we think about cardiovascular disease, I feel like we almost always default to a plumbing analogy.
Oh, 100%. Like a pipe just getting clogged.
Right. A pipe gets clogged with sludge, the blood stops flowing, and, the system fails.
Yeah.
It just sounds like simple, completely passive physics.
Yeah. And it's incredibly comforting to think of it that way, right? Because plumbing is easy to fix. You just snake the drain and you're good.
Exactly.
Yeah.
But if you actually step into the pathophysiology, that analogy just completely falls apart.
Oh, completely. We aren't looking at some, passive sludge building up in a pipe. We are looking at a highly active, totally dynamic, and frankly, dangerous biological war zone.
Which is wild to think about. Yeah. And if you are an advanced practice nursing or physician assistant student gearing up for your exams or your clinical rotations, navigating that exact war zone is basically your primary job.
Yeah, it really is.
So welcome to a special one-on-one tutoring edition of the Deep Dive. Today, we are basically serving as your personal study guides to completely master Chapter 44 of Len's Pharmacotherapeutics.
Which is a heavy chapter, but a crucial one.
Definitely. We're focusing strictly on the prophylaxis of atherosclerotic cardiovascular disease, or ASCVD, and the drugs used to normalize cholesterol and triglycerides.
And the secret to mastering this pharmacology is really resisting the urge to just memorize a list of side effects or dosing charts.
Right, because that just falls out of your brain right after the test.
Exactly. Once you understand the underlying pathophysiology, like why a drug is chosen to intervene in that specific biological war zone, how to dose it and monitor it becomes entirely logical. It just all snaps into place.
That makes so much sense. So before we can deploy the therapeutics, we really have to understand the enemy. And I guess that starts with where cholesterol actually comes from.
Yeah, exactly. We have exogenous sources from our diet, obviously, but the vast majority is endogenous. It's manufactured primarily by the liver.
Okay, so the liver is the main factory.
Right. And a critical step in that manufacturing process is catalyzed by an enzyme called HMG-CoA reductase.
HMG-CoA reductase.
Okay, got it. Now, here is a fascinating thing. If a patient eats more dietary cholesterol, the liver simply downregulates its own production. It compensates.
Wait, really? So just eating cholesterol isn't the main problem?
No, the real issue is saturated fat. When a patient eats a diet high in saturated fats, the liver takes those raw materials and just uses them to manufacture a massive amount of endogenous cholesterol.
Oh, wow.
Yeah, so reducing dietary saturated fat is actually far more clinically significant than just cutting out dietary cholesterol itself.
Okay, that is a huge clinical distinction. So once the liver makes its cholesterol, how does it get around? Because lipids are hydrophobic, right? They can't travel freely in the watery plasma of the bloodstream.
Exactly. They just separate like oil and water. So the body packages them into lipoproteins. The core is hydrophobic, so it packs in the cholesterol and triglycerides. And the outer shell is hydrophilic, which allows the whole package to dissolve in the blood.
And embedded in that hydrophilic shell are apolipoproteins, right?
Yes, apolipoproteins. These are essentially like cellular address labels. They act as recognition sites that allow specific cells to bind with and ingest the lipoprotein.
Okay, so based on those address labels and whatever's packed in the core, we clinically track three major classes.
Right, let's break them down. First, you have your very low-density lipoproteins, or VLDLs.
The VLDLs.
Yeah. Think of these as delivery trucks carrying triglycerides from the liver out to the muscle and adipose tissue. And a key clinical pearl here, if triglyceride levels exceed 500 milligrams per deciliter, the patient is at severe risk for acute pancreatitis.
Oh, wow. Okay, so VLDLs equal triglycerides and pancreatitis risk. What's next?
Next, we have low-density lipoproteins, LDLs. The primary core lipid here is cholesterol, and their job is to deliver it to non-hepatic tissues. But these are the direct contributors to atherosclerosis.
It's bad cholesterol.
Exactly. The higher the LDL, the higher the ASCVD risk. Dropping LDL by just 1% translates directly to about a 1% drop in the risk for a major cardiovascular event.
That is a wildly direct correlation.
It really is. And counteracting them are the high-density lipoproteins, or HDLs, the good cholesterol.
Right, the HDLs.
Yeah, they carry cholesterol away from the peripheral tissues back to the liver to be processed and removed. So high levels of HDL actively protect against ASCVD.
I always picture LDLs as these, reckless dump trucks just carelessly driving through the bloodstream, dropping off cholesterol, and literally crashing into the arterial wall.
That's a great way to visualize it.
And then the HDLs are the street sweepers coming along behind them, cleaning up the spilled cholesterol and driving it safely back to the liver dump.
Exactly. But to understand the actual genesis of ASCVD, we have to look microscopically at what happens when those dump trucks crash.
The war zone.
Right, the war zone. It starts when LDLs penetrate the subendothelial space. That's the area just beneath the inner lining of the artery. Once trapped in that wall, the LDLs undergo oxidation.
Okay, wait. Why does oxidation specifically trigger the immune system? Because, we have LDLs all over the body, but suddenly this chemical change turns a misplaced molecule into a full-blown crisis.
Well, the oxidation alters the molecular structure just enough that the immune system no longer recognizes it as self.
Oh, so it thinks it's an infection.
Exactly. It views the oxidized LDL as a toxic invader. That triggers the endothelium to release inflammatory chemokines, which pull monocytes out of the bloodstream and directly into the arterial wall.
So the immune cells rush in.
Right. Those monocytes transform into macrophages and just start engulfing the oxidized LDLs. They gorge themselves so aggressively that they swell up and turn into what we call foam cells.
Foam cells, that sounds awful.
It is. As those foam cells accumulate in the wall, they form a fatty streak. It makes the artery wall lumpy, creating turbulent blood flow.
Which is the start of the plaque.
Yeah. Over time, smooth muscle cells migrate to the area, synthesizing collagen and forming a fibrous plaque over that lipid core.
And this is where the plumbing analogy really dies, right?
Yeah.
Because it's not just sitting there.
Right. If that fibrous cap is weak, the turbulent blood flow can tear it open. And the split second it ruptures, it exposes the underlying highly thrombogenic tissue to the blood.
Which causes a clot.
A massive one. It triggers an immediate platelet aggregation cascade. A thrombus forms, completely occluding the artery, and that results in a myocardial infarction or a stroke.
Wow. Okay, so with that pathophysiology established, clinicians have to decide who actually needs pharmacological intervention. And looking at the 2018 ACC8 guidelines, they really moved away from just chasing an arbitrary LDL number, didn't they?
They did, yeah. They shifted focus entirely to assessing a patient's overall 10-year risk for a clinical coronary event.
And they used the Framingham Risk Prediction Score for that, right?
Exactly. The Framingham score calculates risk using age, total cholesterol, HDL levels, smoking status, and systolic blood pressure.
But, noticeably absent from that calculator equation is diabetes.
Yes.
And that's because diabetes is no longer considered just another variable to plug in, right? It's classified as an ASCVD risk equivalent.
Precisely. From a clinical standpoint, treating a patient with diabetes is functionally the exact same as treating a patient who has already had a heart attack.
Wait, really?
That's severe.
Yes. Chronic hyperglycemia causes profound damage to the vascular endothelium. It sets the perfect stage for those LDL dump trucks to crash.
That makes total sense. So looking at the guidelines, they funnel patients into one of 4 statin benefit groups based on clinical context.
Right. Let's walk through those 4 groups.
Okay. So you have secondary prevention for patients who already have clinical ASCVD.
Group 1. Yep.
Then you have primary prevention for patients with severe hypercholesterolemia, meaning an LDL of 190 or higher.
Right. Group 2. The third group covers patients aged 40 to 75 with diabetes, regardless of their baseline LDL.
Exactly.
And finally, Group 4 covers patients aged 40 to 75 without ASCVD or diabetes, but whose calculated 10-year risk score hits 7.5% or higher.
That's the breakdown. But, it's crucial to remember that even if a patient lands in one of those groups, therapeutic lifestyle changes, like diet, exercise, smoking cessation, are always the baseline intervention.
Always.
Always. Pharmacotherapy is an adjunct to lifestyle changes, never a substitute. And because LDL levels will rebound within weeks if the drug is stopped, prescribing these medications represents a lifelong commitment for the patient.
Right. You can't just take a statin for a month and be cured.
Exactly.
Now, we also need to address metabolic syndrome, which acts as a secondary target for therapy. A diagnosis requires 3 of 5 markers: high triglycerides, low HDL, hyperglycemia, high blood pressure, and a large waist circumference.
Yeah, those 5.
But there is a massive, philosophical divide between cardiologists and endocrinologists over this label. Wait, so is metabolic syndrome An actual disease or just a catchy name for 5 bad things happening at once?
That is exactly the debate. Cardiologists tend to favor the term because it conveniently flags high-risk patients in one neat package.
Right.
But endocrinologists argue that metabolic syndrome isn't a distinct disease at all. They see it as a cluster of separate risks without a single unifying pathology, meaning the total risk is simply the mathematical sum of its parts.
So it doesn't really matter what you call it. You still have to treat the parts.
Precisely. Regardless of the philosophy, both specialties agree these individual risk factors require aggressive management. For instance, if a patient has triglycerides over 200, lifestyle changes are initiated first, followed by statins, and then fibrates if the levels remain dangerously high.
Okay, so let's talk about the heavy artillery. Statins are the primary weapon. They are HMG-CoA reductase inhibitors, and that includes mainstays like atorvastatin, lovastatin, and rosuvastatin.
And in terms of efficacy, they are the undisputed gold standard. High-intensity statin therapy can drop LDL by over 50%, with some peaking at like a 63% reduction.
That's a massive drop.
It is, but their benefits actually extend far beyond just lipid lowering. They have profound pleiotropic effects.
Meaning they do other things besides just lower the numbers.
Exactly. They actively stabilize the fibrous cap of existing plaques and reduce inflammation at the site of the lesion. This directly prevents the ruptures that cause acute events.
So wait, the mechanism of action is brilliant. The statin doesn't actually circulate in the blood, destroying the cholesterol directly, right?
No, not at all.
It simply inhibits HMG-CoA reductase, basically starving the liver's manufacturing plant.
Right.
And the liver panics because it needs cholesterol to function, so it compensates by synthesizing more LDL receptors on its surface. We're weaponizing the liver's own supply chain. We force it to vacuum LDL out of the systemic circulation.
Yes, weaponizing the liver is the perfect way to phrase it. And because we are manipulating the liver's natural rhythm, dosing timing is actually really important.
Oh, because of when the liver works.
Exactly. Endogenous cholesterol synthesis naturally peaks during the night. Therefore, statins with shorter half-lives are most effective when administered in the evening.
Okay, but prescribers can easily get into trouble with the pharmacokinetics, right?
Right.
Because atorvastatin, lovastatin, and simvastatin rely heavily on the CYP3A4 hepatic enzyme pathway for metabolism.
Yeah, that is a huge red flag area. Any substance that inhibits CYP3A4 will cause statin levels to accumulate in the blood, leading to severe toxicity.
What kind of substances are we talking about?
This includes macrolide antibiotics, azole antifungals, HIV protease inhibitors, and notably, grapefruit juice.
Grapefruit juice, right. Always on the test.
Always. There is also a distinct safety alert regarding rosuvastatin in Asian patients.
Oh, yes, let's cover that.
Due to genetic differences in drug transport proteins, rosuvastatin blood levels can reach twice the concentration seen in Caucasian patients on the identical dose.
Twice the concentration.
Yes, so you absolutely must initiate therapy at a significantly lower dosage for this population.
Okay, so what happens if those blood levels do spike? We see 2 primary toxicities, right? Hepatotoxicity and myopathy.
Right. Myopathy begins as unexplained muscle aches and weakness. Rarely, it progresses to myositis, and even more rarely, to full-blown rhabdomyolysis.
And rhabdo is catastrophic.
Completely catastrophic muscle breakdown. The dying muscle cells release a massive protein called myoglobin into the blood. And as the kidneys try to filter those massive molecules out, they literally precipitate and physically clog the renal tubules.
Which causes acute renal failure.
Exactly. Acute tubular necrosis and renal failure. So if a patient reports muscle pain, you immediately check their creatine kinase or CK levels to assess for muscle damage.
What else should you check?
Checking thyroid function, vitamin D, and CoQ10 is also prudent because deficiencies there actually lower the threshold for myopathy.
Good to know. Now, with hepatotoxicity, obviously we are monitoring liver function tests, but the clinical context of the liver disease dictates the prescribing logic, right?
Yes. Statins are strictly contraindicated in patients with active viral hepatitis or alcoholic hepatitis.
Because the liver is acutely inflamed.
Right. However, if the patient has non-alcoholic fatty liver disease, statins are not only safe, they are often beneficial in reducing hepatic inflammation.
That's a great distinction. Now, we also have an absolute contraindication in pregnancy.
Oh, absolutely contraindicated. The developing fetus requires a huge amount of cholesterol to build cellular membranes and synthesize vital hormones. Inhibiting that supply chain causes severe fetal malformations.
And this presents a massive liability trap in primary care, doesn't it? Because about half of all pregnancies are unplanned.
Yes, and with rising obesity and diabetes rates, we are seeing more and more women of childbearing age who technically qualify for statin therapy based on metabolic risk.
Right.
So prescribing a statin to a 35-year-old female without having a rigorous conversation about contraception is a major, major clinical error.
You absolutely have to have that conversation. So if a patient cannot tolerate statins due to myopathy, or maybe they have active liver disease, we have to find alternative ways to force the liver to clear LDL.
Right. Which leads us to the backup squad. The bile acid sequestrants, like colesevelam.
You know, these drugs are fascinating to me because they are biologically inert. They are essentially microscopic sand.
Yeah, that's exactly what they are.
The patient swallows the resin, it travels to the GI tract, and it binds irreversibly to bile acids. It is completely unabsorbed by the systemic circulation, and the bound bile is simply excreted in the feces.
And since bile acids are synthesized from cholesterol, forcing their excretion creates a deficit.
Which tricks the liver again.
Exactly. The liver responds to this bile shortage the exact same way it responds to a statin-induced cholesterol shortage. It upregulates its surface LDL receptors, pulling more LDL out of the bloodstream to manufacture replacement bile.
Okay, but if bile acid sequestrants are essentially just sand that stays in the gut and isn't absorbed systemically, why aren't they the first choice over statins? I mean, why risk the liver and muscles with a statin when you have this incredibly safe alternative?
It's a totally fair question. It comes down to clinical outcomes and patient compliance.
Okay.
While sequestrants definitely lower LDL, we do not see the massive reductions in cardiovascular mortality or the vital pleiotropic plaque stabilizing benefits that statins provide.
Oh, they don't stabilize the plaque.
No. Furthermore, because they are essentially sand moving through the gut, they cause severe gastrointestinal side effects.
Right. Bloating, cramping, severe constipation.
Very severe. And they also non-specifically bind to other oral medications in the digestive tract, preventing their absorption.
So they trap other drugs too.
Yes. If a patient is taking thiazide diuretics, digoxin, or warfarin, the sequestrant will trap those drugs. So you have to carefully time administration, giving the sequestrant at least 1 hour before or 4 hours after any other medication.
That sounds like a nightmare for patient compliance.
It really is.
Now, we can also block absorption right at the intestinal wall using ezetimibe.
Yeah, ezetimibe targets the brush border of the small intestine to physically block the absorption of dietary cholesterol and cholesterol secreted in bile.
And it's usually used with a statin, right?
It is highly synergistic when combined with a statin. It often yields an additional 25% reduction in LDL.
But there are interactions to watch out for.
Definitely. It should not be combined with fibrates due to a heightened risk of gallstones, and combining it with sequestrants will actually block the ezetimibe itself from being absorbed. It is also contraindicated in patients with moderate to severe hepatic impairment.
Okay, so shifting focus away from LDL for a second, we need to address patients who are primarily struggling with high triglycerides, particularly those at risk for pancreatitis or those presenting with metabolic syndrome.
Right.
The target here is the VLDL delivery trucks, and the pharmacological weapon is the fibrates, like gemfibrozil.
Exactly. Fibrates are the most effective agents available for lowering triglycerides because they actively decrease VLDL production and increase its clearance.
But they are third-line therapies, right?
They are, because clinical outcome trials have repeatedly demonstrated that, unlike statins, fibrates do not reliably reduce overall ASCVD mortality.
Wait, so patients with metabolic syndrome often have high LDL and high triglycerides.
Yeah.
But if you combine a statin for the LDL and a fibrate for the TGs, you drastically increase the risk of muscle breakdown, right? That sounds like a prescribing minefield.
It is a massive minefield.
Yeah.
Combining gemfibrozil with a statin drastically increases the risk of rhabdomyolysis. It is generally avoided whenever possible.
And there's an issue with warfarin, too.
A huge one, involving a different mechanism entirely. Gemfibrozil is highly protein-bound and aggressively displaces warfarin from plasma albumin.
Oh, so it knocks the warfarin loose.
Exactly. When the warfarin is knocked off the albumin, the levels of free active warfarin in the blood spike, creating a massive bleeding risk. If a patient must be on both, you have to strictly monitor their INR and frequently reduce the warfarin dose.
So a safer alternative for isolated hypertriglyceridemia involves prescription-grade fish oils containing EPA and DHA, right?
Yeah.
Like Lovaza and Vascepa.
Yes, both effectively lower triglycerides, but Vascepa, which contains only icosapent ethyl, is unique in this class because it has demonstrated proven cardiovascular outcome benefits in clinical trials.
Any adverse effects to watch for with those?
The primary adverse effect for these high-dose omega-3s is a prolonged bleeding time, so you need caution if the patient is concurrently taking anticoagulants or antiplatelet drugs like aspirin.
Okay, so for the final section here, what happens when a patient is maximizing their lifestyle changes, taking the highest tolerated statin dose, maybe even combining it with ezetimibe, and their LDL still remains dangerously high?
Yeah, which is incredibly common in patients with heterozygous familial hypercholesterolemia.
Right. So we have to escalate to the newest biologic agents, starting with PCSK9 inhibitors like ilacumab and evolocumab.
Yes. And to grasp how they work, you have to understand the normal physiological role of PCSK9. It is a protein synthesized in the liver that binds to LDL receptors on the cell surface and targets them for degradation.
So it destroys the receptors.
Exactly. It is the body's natural way of keeping the LDL receptors in check. By injecting these monoclonal antibodies subcutaneously, we bind and inhibit the free PCSK9 protein.
I love the biological bouncer analogy for this. It makes it crystal clear.
It really does.
So the LDL receptors are the bouncers standing outside the liver, grabbing the bad LDL and kicking it out of the bloodstream. PCSK9 is a hitman hired by the body to eliminate those bouncers.
Right.
So these new monoclonal antibodies basically take out the hitman. Without PCSK9 destroying them, the bouncers survive much longer and can continuously clear LDL from the blood.
It's a brilliant mechanism. But because these drugs are large therapeutic proteins, they carry unique risks. We monitor for hypersensitivity reactions at the injection site, and more importantly, we watch for immunogenicity,
where the patient's own immune system attacks the drug.
Exactly. They recognize the drug as foreign and develop neutralizing antibodies against it, which renders the therapy totally ineffective over time.
Okay, and finally, we have the ACL inhibitors with bempedoic acid as the prototype.
Right. Bempedoic acid works within the exact same cholesterol biosynthesis pathway as statins, but it targets an enzyme upstream. It inhibits ATP citrate lyase.
So it's blocking an earlier step.
Exactly. By blocking this earlier step, it starves the liver of cholesterol just like a statin does, achieving the identical end result, the massive upregulation of LDL receptors to clear blood cholesterol.
But the side effect profile requires vigilance. It causes hyperuricemia, which can precipitate intense gout flares.
Yes, and it also carries a unique and strange risk for tendon rupture.
Tendon rupture, really?
Yeah, particularly the Achilles or biceps tendon. That risk is significantly elevated in older adults, or those concurrently taking fluoroquinolone antibiotics or systemic corticosteroids.
That is definitely something to remember for clinicals. Does it interact with statins?
It does. Bempedoic acid interacts with specific statins, notably increasing the blood concentrations of simvastatin and pravastatin, requiring a strict dose limitations if they are co-administered.
So looking back over the entirety of Chapter 44, the logical through line is just undeniable.
It really is.
The microscopic pathophysiology of atherosclerosis, like the oxidized LDL, the foam cell accumulation, the unstable inflammatory plaque, perfectly dictates the therapeutic goals established by the ACHA guidelines.
Exactly. And those goals drive rational drug selection, positioning statins as the cornerstone not just for lowering lipid numbers, but for their structural stabilization of the plaque itself.
And understanding how those drugs alter the liver's supply chain directly informs the precise monitoring parameters, from LFTs and CK levels to navigating complex CYP3A4 and protein-binding interactions.
You really cannot safely prescribe in this space without understanding every single link in that chain.
Absolutely not. But as you, the listener, transition from this material into your clinical rotations, I want to leave you with a final thought to mull over.
Yeah, a bit of a provocation.
We know statins dramatically lower LDL, reduce vascular inflammation, and save lives. We know fibrates successfully lower triglycerides, but they fail to improve overall mortality.
Right.
It makes you wonder, is atherosclerosis truly driven by the mere mechanical presence of cholesterol sludging up the blood? Or is the actual disease driven by the immune system's hyperactive inflammatory reaction to it?
It's the million-dollar question. If inflammation is the true villain of the story, how might future biologics change the landscape of cardiovascular disease entirely?
Right. We might eventually look back at pure cholesterol-lowering strategies the same way we look back at treating a fever without treating the underlying infection.
It is the defining question for the next generation of cardiovascular pharmacology.
And you're the one who will be answering it in practice. From all of us here at the Deep Dive and our special last-minute lecture team, thank you for tuning in. You are now fully prepped to tackle your pharmacology exams and your clinical rotations safely and confidently. You've got this. We'll catch you next time.